Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. Our webinar today is being presented in collaboration with Mindray, an ultrasound device manufacturer. Please stay tuned at the end of the webinar to hear important messages from the POCUS Certification Academy and Mindray. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's presentation will include a PowerPoint presentation, time for questions and answers, and important messages from our collaborators. Today's topic is POCUS in Pediatric Airway, the new generation stethoscope. And our speaker is Dr. Deepa Shivnani. Dr. Deepa is an otolaryngologist who has completed her fellowship in pediatric otolaryngology with advanced training in pediatric airway. She is a highly motivated surgeon with over 5 years of experience in a tertiary care hospital in India. During her practice, Dr. Deepa realized the need for a non-invasive screening technique for timely evaluation of pediatric airway disorders in the emergency department. Dr. Deepa's objective is to improve the quick diagnosis and treatment plan in critically compromised airway and provide a cost-effective and non-invasive alterative diagnostic solution for pediatric patients. Dr. Deepa is also the POCUS Certification Academy's POCUS Ambassador to India. Thank you, Dr. Deepa, for being with us today.
Good evening and good morning, everyone. Thanks for joining for this talk today. Thank you, Point of Care Ultrasound Academy, for giving me this opportunity. Thanks to Mindray for collaboration and allowing us to spread our knowledge about point of care ultrasound, POCUS in pediatric airway, what we feel is the new generation stethoscope. So, hi all, this is Dr. Deepa Shivnani. I work in Children's Airway and Swallowing Center, Manipal Hospital, Bangalore. So, Manipal Hospital is a great chain of more than almost 27 centers across 14 cities all over the India. So before I start my talk, let me disclose that I am the POCUS Ambassador of 2021 cohort. Other than this, I have nothing to disclose, no conflicts of interest. So let's talk about the objective. I will be taking you through the significance of POCUS for evaluation of pediatric airway, followed by what kind of probes we can use, how to use the POCUS appropriately, what is the method, what is the position of the child, and then we'll go to the airway pathologies, how to assess and identify the lesions with the help of ultrasound device. So let's go to the first topic of significance of POCUS for evaluation is pediatric airway. It is very important to understand the problem first. Unless we identify the problem, we will not go for the solution. So let's take these three scenarios, case scenarios, a variety of range of the age, like 28 days old to 5 years old. What problem we face when we examine the child? Let's take the first case, who is a child of 28 days old. For last 2 weeks of life, he has developed some noisy breathing, respiratory distress, and problems while feeding. Parents complain the child is making some noise while breathing, and on examination, this was the presentation. As you can see here, the child is having significant supraesternal retraction. Child is having inspiratory stridor with feeding difficulty, which is gradually progressed when he was 2 weeks old. Now child is 28 days old. The clinical diagnosis of Laryngomalacia was made. But how to confirm the diagnosis? Now go to the next case. This is the child, almost an year old. Post cardiac surgery, child developed respiratory distress, breathing issues, and some noisy breathing, and the ENT referral was given for further evaluation. Child is having significant subcostal retraction, inspiratory noise, and then supraesternal retraction as well. Then take the third scenario, who is pretty big girl, 5 years old. She came with a complaint of respiratory distress more when she is playing and doing some physical exercise. This was the presentation.
Breathe, breathe. Mama is here only. Breathe. Breathe. Very good.
She breathes, she is having sound. She is having supraesternal retraction. The mommy is next to her. Still, she is scared. You know, this age of kids, they're scared the moment they feel that, oh, they are going to hospital. And I did not do anything. We just took her for the evaluation. We just put the saturation probe to check why she is in distress, whether she is maintaining saturation or not. And then she started crying. It was very difficult to counsel her that we are not going to do anything. We are just examining what is the problem. So this is the challenge. The child comes to you with various problems of upper airway, and how will you examine? So what is the traditional method of examination of these cases? If child is very small, you can take the child, you can hold the child, and we have to do flexible laryngoscopic examination, which is a standard method to look for the upper airway. But as you can see, this is an invasive procedure. You are putting the tube inside the child. You are holding the child. Majority of cases, we can avoid the sedation if you are holding nicely and if the baby is small, but it should be done in controlled setup. You have to keep the oxygen ready. You have to keep IV cannula ready. You know, these tiny kids can anytime go into bronchospasm, anytime they go into bradycardia. So you have to do such procedures in controlled setup. Or if the child is little bigger, he will definitely not allow you to do this invasive procedure without sedation. So you have to give sedation. Or the other option, go take the child into the OR operation room and do direct laryngoscopy under complete general anesthesia. And here the problem becomes more bigger if that comes into the COVID times. Like you don't know the status of the child, whether he's COVID positive or not. You have to do this upper airway examination, which is again an aerosol generating procedure. You have to take all precautions with your PPE and all. And again, the cost will go high. So once we identify this problem, then only we can think for the solution. As someone rightly said, that necessity is the mother of invention. So what invention we look for? I'll just take one simple examination. We all are using mobile phones, but you know from where this phone has come. Almost 100 years ago, more than 100 years ago, Sir Alexander Graham Bell invented this device, the telephone, the wired instrument which can do the communication, distant communication better. And what is new generation telephone, you tell me? I'm sure half of you must be attending my talk on your mobile phone itself. So where are we? We are on this smartwatch where on single wrist, you can use your Gmails, your GPS, your calls, your messages, everything. So this is called innovation, the new generation telephone. And where are we if we talk about the innovation in medical field? Just take about the stethoscope. What is new generation stethoscope? That was more than 100 years, but here we are exactly more than 200 years, where first time by Sir Linac, the stethoscope was devised, and we went to the double lumen, similar design to the single lumen with similar size and design today. What advantage is there extra? That we have got this digital stethoscope with the auscultation where we can auscultate the sound, and at max you can get the ECG leads on this tiny device. Is this the new generation stethoscope? No. Some studies have come recently, if you can see from 2017, 18, 19, where they have discussed the role of point of care ultrasound in upper airway evaluation. In fact, they have diagnosed Laryngomalacia in infants with the help of ultrasound or other dysphonia or Stridor condition. But the best what I found is this article in the Lancet, which says to truly look inside, where the author has compared the normal stethoscope to the digital one and this portable ultrasound device, and they found that anatomical information was only available when you do the ultrasound examination. And the accuracy of interpretation was more than 95% when they use this point of care ultrasound as compared to stethoscope and the digital stethoscope. So what is POCUS? yes, it is nothing but the point of care ultrasound, where we use the ultrasound at bedside to the patient side to answer specific diagnostic questions. We all know that it is well established, it is a validated tool, and people have been using ultrasound for lower airway, for endotracheal tube, establishment, for lower airway examination, for pleural effusion, for pneumothorax. But yes, is it safe and validated for upper airway? That is what we are going to talk here. So let's take our first polling question here for you all. So here's a question, it's popping out on your screen, and it would be great if we can make this session interactive. I would like to know what is your appropriate answer. Who can perform point of care ultrasound procedure on the child? Is it a radiologist? It's an intensivist or anesthetist, both A and B, or an ENT specialist, or any physician who is attending the patient at point of care? So I think Mr. Tori must be calculating this. What is the time for polling?
Yeah, we're going to give, they're still coming in pretty fast here, so I'm watching. So we'll give you just a few more seconds, get your last option selected, and then we'll show the poll live here in one moment.
Right.
And there should be your results.
Oh, that's cool. Okay, 70% rightly said that any physician who is attending the patient at point of care. Good. So this is what POCUS is. So according to American Medical Association, they have given the resolution to promote point of care clinical ultrasound, and they said that any clinical attending physician who is using ultrasound for their dedicated zone and specialty, they are allowed to do the ultrasound. So it's not that only radiologist is required. If you are examining the child, if you know how to use the technology, you can go ahead with your examination and diagnosis of the child with the help of POCUS. Mr. Tori, can we go ahead? All right. So here comes why we are looking for ultrasound. And I would request Mr. Tori again to put one more question for you all, that ultrasound of the pediatric airway is a painful procedure or can cause discomfort sometime. Is it true or is it false? Now, some must be thinking, yeah, could be true. Kids are always kids. They might cry. They might feel some discomfort. Some might be thinking, if it is that easy, why would I ask? It could be false. No, it is pretty safe, 100% safe. And we'll see the results soon.
Okay, just a few more seconds here on your second poll. They're still coming in, so get your last answers in. Okay, and Dr. Deepa, here comes your results.
Oh, good. So that made my job easy. Okay, people know that definitely this is a painless procedure. It doesn't give discomfort to the child. So this statement is false. Why we are looking for the ultrasound when we already have the gold standard flexible scopy or direct laryngoscopic examination? Because this procedure is non-invasive. I think if some of the ENTs are here, you must have faced this problem. No matter you tell parents that, yes, you're going to see the child's upper airway with the laryngoscopic examination. It is pretty safe. We are not giving the sedation to the child. And it's just the 10 minutes procedure. But 1% in your statement, in your counseling, you must be telling that in 1% chances are their child might land up into bradycardia, bronchospasm. We might admit the child for a longer duration for admission, or we might give the sedation and little discomfort if we avoid the sedation. Or yes, it is invasive procedure. So parents take some time to understand and take a call whether to go for this or not. But On the other side, ultrasound is non-invasive, so it is easy to counsel them go for this technique and advancement. Then yes, it is simple and portable. It is not, you are not going to book the OR for the procedure. You don't want any dedicated, endoscopic suit to perform this procedure. Anyway, you just take your device and go for it. It is widely available. Trust me, any hospital will be having at least one ultrasound device for their radiology unit. You can take the child there or take the portable machine there and you can perform this. It is a repeatable procedure as well. It is pain-free and safe as far as pediatric age group is concerned. And it will give you the real-time dynamic images as well. Later in this talk, I will just show you some of these slides at how we have diagnosed the dynamic diseases with the help of ultrasound. And it can be accurate in experienced hands. So this is why we need to look into this. We need to understand this technique, and it's better if we adapt it as soon as possible. So now let's go to the second part, which is selection of the probe and appropriate usage. Before you go and understand this technology, you should know what the Sono Anatomy is. So as we all know that air is poor ultrasound medium, it will give you some artifacts. So the thing is to understand what is normal, what is abnormal, and what are the artifacts we should look for. Then go that, okay, this is the artifact and this is the real pathology. And what area we are looking for majorly, to look for the epiglottis, the hyoid bone, vocal cords and the mobility of the vocal cords, trachea, thyroid gland, thyroid cartilage, thyroid membrane and cricothyroid membrane for the procedures which involve upper airway. So once you are in this Sono Anatomy, that what you should look for, then we will go and see in detail. So there are basically two views. One is the longitudinal view, one is the transverse view. Transverse view also called as short view and longitudinal also called as long view. Transverse view is here what we have shown on the screen. So this is the cut which has been taken in the center, the middle of the thyroid cartilage. The hypoechoic inverted U or V-shaped structure is the thyroid cartilage, which I have labeled as a TTC is for the thyroid cartilage. This is the thyroid gland, the upper lobe, as we know that it can spread from the top to below the till the second or third tracheal ring down. Then this is the arytenoid cartilage, the AC, again the hypoechoic. This isoechoic or hyperechoic sometimes can be appeared by the false vocal cord or the muscles of the vocal cord. Here, this first image is in the adduction where both the vocal cords are approximated. This image in the abduction where you can see the arytenoid cartilage is far apart, and the same, the thyroid cartilage presentation. Next, we go to this cut where hypoechoic structure of the cricoid cartilage, the thyroid gland, just still the lobes are there, but we are not at the isthmus yet. And this is called the comet-tail artifacts. In the trachea, wherever there is two medium changes, we get the reverberation, we get this, this hyperechoic line between. This is called air mucosal artifacts. The reverberation lines will come behind, and this is called comet-tail artifacts. Then this is the cut at the tracheal level. This is the trachea. This is again the reverberation effect, thyroid gland, and this is the isthmus, and these are the strap muscles on top. So once you have understand the anatomy, then you should know which probe we will be using for upper airway evaluation. So basically we need the linear probe would be good, but okay, curvilinear also is fine, but the high frequency probes are important to see the structures of upper airway. So we go for the high frequency transducer. My choice is linear. Some goes for the curvilinear as well for better visualization and increased dimension. For the position of the child, here are two videos. Number one, I'll show that either you can keep the child on mother's lap or caregiver's lap with the neck a little bit extended. Put your probe and examine the child. Child can be engaged or entertained with either with the music or a little bit moving if required, if you are just tracing. Otherwise, the better would be if child is still and stable to capture the good images. Or child can be kept on the pillow, again with the neck extended, and you can use some rattle or some toy for the engagement of the child, and you can perform the procedure. Once you have positioned the child, then time comes for your probe selection. So once you have selected and connected the probe, look for the marking on the probe. Right should go with the right, because we will be looking for the pathologies. If the lesion is on the right side, there should not be mistaken that you have seen the lesion on the left, or the probe was kept reversed. So make sure you understand that you are putting the pointer at the appropriate site and direction. Then it is better if you can relax this wire on your neck, so the stretch and bending will be less on the probe. Keep the child position, keep ready the recording, tell the child to extend the neck and be comfortably breathe, and put your probe on the neck with the gel on it, and you are good to go. Now you have understood what is the anatomy, what probe to use, how to position the child, how to perform the procedure, but what to look for. So here comes our third discussion topic: airway pathologies, assessment and identification by POCUS. So one more question for you all. POCUS of pediatric airway can be used to evaluate airway intubation, vocal cord mobility, both A and B, some airway lesions, or all of the above.
Okay, just a few more seconds on the poll. Get your final answers in. They're still coming in just a few more seconds. Okay, and Dr. Deepa, here are your results.
Okay, again we are passed. Okay, so people know that, right? All of the above can be identified with the help of point of care ultrasound device. So let's talk about it. So there is one child first who has come with this Stridor. I showed you the similar video before where the clinical diagnosis of Laryngomalacia was made. Again, I just repeat, there is a child, 28 days old male child, who is having inspiratory Stridor, some breathing difficulties, and some feeding issues. Clinical diagnosis of Laryngomalacia was made. And when we did the ultrasound, this was the presentation. The dynamic collapsibility of the supraglottic structure, which we confirmed on the endoscopy on the right, that supraglottic, the epiglottis, the arytenoid tissue just goes, collapse and closes the airway. So here, if you can appreciate in the middle, it's inverted V appearance is the thyroid cartilage. This is a cut for the vocal cord. These are the vocal cords, arytenoid, and this hyperechoic, the sharp point structure in between, which comes and goes with every breath, is the epiglottis. So this was the dynamic evaluation on the basis of ultrasound. Then comes the second question: hoarseness with vocal cord nodules. So there was a child, he was 3 years old. For last 1 month back, he developed some cough and cold, followed by he developed hoarseness of voice. Parents went to 2 different hospitals. He was being treated with the anti-allergics, anti-acid, anti-reflux measures, with some speech therapies. In spite of all measures, his voice was not improved. So parents came to us for second opinion.
1, 2, 2, next, 2 के बाद 3, 4, 5, 6.
I think you can appreciate the hoarseness, but what is the solution now? What you are going to do in this scenario? When parents told me that this is the case, he had cough and cold followed by this voice change, I had a one differential diagnosis. Okay, he must be having laryngitis, which might settle down over a period of time. Then I asked one more question: did he scream a lot? Parents said yes, he always screams and talks loudly. So the second differential came in my mind: he might be having vocal cord nodules, but how to confirm? He is 3 years old. He's not going to examine, he's not letting me examine for the vocal cords on the flexible scopy, I had to counsel the parents that, okay, we'll go and do rigid endoscopic examination and have a look on the vocal cord. Then parents ask, what if it comes normal? The cost will go, the time will go. What we are going to achieve? Okay, so I didn't have any answer. But what if I'm going to use the ultrasound on the same patient, which gives me, okay, this is again the hypoechoic thyroid cut, this is the vocal cord level cut, transverse level, and one hyperechoic lesion is sitting right at the middle of the anterior 1/3 and posterior 2/3 of the vocal cord. This is some pathology. I was pretty confident to counsel the parents, yes, we need to look it, and we are sure that we will be getting something inside which has to be corrected surgically. And that is how the ultrasound device helped us to counsel our parents in a better way. Then comes another application of assessment of surgical field. Another case scenario, we had a child who was 16 years old, admitted in PICU. Child was already on ECMO. ECMO is the lung heart bypass machine. Here you can see the multiple wires and tubing is going into the neck. We got a call for tracheostomy in this child. Tracheostomy was challenging in 2-3 ways. Number one, we had a very limited neck exposure here. Everywhere on the right and left, child is taped with the tubing. So I have to work in a precise way. Number two, child was on ECMO. Child was having continuous heparin infusion, which they couldn't stop, which can cause severe bleeding. Number three, we had to perform this procedure bedside in PICU. We cannot ship this child with this ECMO machine to the operation theater. So I had to be a little more confident how safe I will be if I'm doing the tracheostomy bedside. The ultrasound helped me. I did the ultrasound examination to see exactly at the thyroid cut, at the level 2 tracheal ring from the stomach down, how many blood vessels I'm going to encounter. How is the trachea? What is the size? There was no blood vessel. The field was little lateral. I was more confident, okay, the central airway is pretty safe. I have got decent place there, and I performed the tracheostomy safely without any blood loss, without stopping the heparin infusion as well, thanks to point of care ultrasound device. Then comes another application of tracheal diameter assessment. Let's take another case here. We have a child who is 4 years old, who is already on tracheostomy size 4 inner diameter. Why we took this child? This child was a known case of central hypoventilation syndrome, who was using BiPAP support whenever child sleeps because he was not maintaining saturation. Child grew up. Now parents came with a complaint that, okay, child is talking, child is having some global developmental delay with delayed in speech as well. They came to us with the request, can we upsize the tube because there is an extensive leak on BiPAP, but upsize in such a way that his speech therapy session should not be compromised. He should be able to talk. We all know that less than size 6, we don't have the double lumen tube speaking wall available easily in India. What to do in such case? The option is, just as global developmental delay agitated child will not allow you to do try and error, and already he was on age appropriate, according to the chart, age appropriate tracheostomy size 4 inner diameter tube. What to do? Again, take for the theater exposure under general anesthesia, see the airway and upsize the tube to 4.5 or 5, put the BiPAP machine and check how much is the leak. And keeping this in mind that there should be some peritubal space so that child can talk. What we did, again, ultrasound helped us. We did the measurements at the tracheal levels where the tube was sitting. We came to know that this child is having the tracheal diameter of 1.01 centimeter. He was on tracheostomy tube. The inner diameter of the tube was 0.4 centimeter, which coincide and confirms that he's on size 4 tube, with the outer diameter of 0.58, which again coincide with the outer diameter of this Bivona tube. And then we came to know, okay, we can go up till 1 centimeter. Then we found size 5 inner diameter can go to 6.9, and then 6, if I take the 6, the outer diameter goes to 9.6. If I choose size 6, the outer diameter will go pretty high, and then we might compromise on speech. If I choose size 5, it will give me the decent outer diameter with peritubal space, and I can avoid some leak on the biped. And that is how we can take the call, and ultrasound can help us in diagnosis of tracheal diameter proper dimension. And this is very interesting. Ultrasound in surgical decision making. Here was a child who was 3 years old, again referred to us for second opinion. Actually, parents only wanted to take second opinion. Parents complain whenever child is talking, child is getting some bulge on the neck, and when they showed to ENT, they diagnosed it as a laryngocele and planned for the procedure, laryngoscopic examination, and proceed, probably excision of laryngocele. So this is a presentation.
1, 2, 3.
If you can appreciate, he's getting some bulges in the neck. Okay. Clinically also, the bulge look little down as compared to the typical laryngocele presentation, but this can also happen if laryngocele is pretty big.
4, 5, 6, 7, 8, 9, 10.
So what to do? You would like to go for the radiological examination, or by CT or MRI, or you want to take the child directly up to the theater for direct laryngoscopic examination? Let's have a look on the ultrasound. We can do the ultrasound. Okay, this part I did not explain to you before. So the vessels, two types of vessels, artery and vein. So artery will be non-collapsible on the ultrasound, circular, pulsatile, and the veins, if you put the pressure more with the probe, veins can be collapsed, and they come with a color Doppler also. You can identify which one is the vein, which one is the artery, and then look for it. So look to this ultrasound. This is the carotid artery. Next to it is the internal jugular vein. So here is the child.
Say E.
Oops, what is this? When child is talking, something is bulging, which mommy is able to appreciate. This is nothing but the internal jugular vein phlebectasia, which is a common condition in pediatric age group, most common on the right side, self-resolving, and importantly, no intervention required. Just wait and watch. So can you believe one ultrasound device can decide, or can give you a path or thought process for surgical decision making? After seeing this, we were 100% sure there was no connection with the swelling to the inner airway or our upper airway near the larynx, nowhere around the larynx. So the diagnosis, the confirmed diagnosis of IJV phlebectasia was made, and parents were reassured without any surgical intervention. So I think now you are pretty clear that why ultrasound is important. So every technology comes with some limitations. So we do have limitations for this ultrasound device, as it comes with some, there is some learning curve. You have to spend a lot of time to see all those black and white and gray images, and try to train your brain to, identify what is normal, what is abnormal or pathological, what are the artifacts, and sometimes inter-observer variation can also happen. So at the end, to conclude, I would like to, revise this all, that already this ultrasound device is established in case if the, the anesthetist wants to do the intubation, the difficult intubation, to check for the endotracheal tube position, whether it is in trachea or in bronchus, to do the cricothyroidotomy in emergency conditions like in adult ER or in adult ICU, to look for the pneumothorax, to look for the pleural effusion. I think, in fact, advanced machines have come, some calculation of the pleural effusion. They keep the probe, like, urinary bladder post residual amount. They can check what is the pleural effusion amount in child's lung. Or now it is evolving and establishing for the tracheal diameter assessment, to look for the vocal cord lesions, dynamic assessment, to look for vocal cord mobilities or airway emergency management for tracheostomies, plan for decannulation, look for subglottic stenosis, look for laryngeal papillomatous lesion, vocal cord lesions, and surgical decision making. So this is how the point of care ultrasound we are going to use in pediatric upper airway evaluation. And trust me, kids used to love this stethoscope, the 200 years old stethoscope, which we are still using for, auscultation. They love when they listen their own heartbeat. Trust me, they are more fascinated when they see their own anatomy. And some of the kids, they just want to look at the screen, and I have to keep their head end on the ultrasound machine so that they can extend as much as possible. They are happy. They are saying inside their body, I am happy that I am getting well exposed and extended neck. So I'll just give my, thanks to my mentor, the director of Children's Airway and Swallowing Center, Dr. Ibiraman sir, for training me that I'm here to get to ready to train others for point of care ultrasound. I would like to say thanks to Dr. Mary Korean, who is a real guy, who's my teacher and who is keep motivating me that, okay, you should go for it. Dr. Jayashree Simha, who is the anesthetist, our pediatric anesthetist. Without her help, we are not able to do any pediatric airway cases. Dr. Nyanam and entire pediatric emergency team, who just give me the confidence that I will take care of this Stridor's breathing difficulty child. You just go ahead with your intervention and look for the pathology. If we can change the scenario, if we can make this point of care ultrasound as a screening tool in upper airway pathologies. And same goes with our NICU and PICU team and my pediatric radiologist, Dr. Bala sir, who tells me and who has rectified, my assessment that we are now going to develop our own POCUS point of care ultrasound atlas of images, what all we have found so far. And at the end, yes, my all patients who trusted me that this is not still validated and established tool for upper airway, but they trust us to allow us to do the examination with the ultrasound device on their tiny kids. So thank you all for patient listening. I have a lot on talk on this point of care, various pathologies and images. If you are really interested, please register for POCUS World Conference and join me on 17th and 18th of September, where I'll be talking about POCUS and alternate to rescue laryngoscopy in evaluation of pediatric airway. Thank you all. Thank you, POCUS team and Mindred team, for giving me this opportunity.
Thank you, Dr. Deepa. Great presentation. We are so happy that you were able to join us today and provide this education for our audience. We do have some audience questions that have come in during the presentation, so we are going to go ahead and jump into those. So I'll just jump in on the first question as they've come in. I'll just read them as they are. Excellent topic, Dr. Deepa. I'm curious to know about how we can learn about this so that we can put this to practice.
Okay, thanks for asking this. In fact, we, the Point of Care Certification Academy, we are planning to develop this course. We are still in process that we will give one structured module, some pre-workshop kind of a material with the atlas where we can tell you how to use the ultrasound physics, ultrasound normal findings, normal upper airway anatomy, and then go to the pathologies. Then to go for some 2 days workshop program, one with the didactic lectures with the expert team, and then day 2 on the hands-on training on actual ultrasound device to look for upper airway screening and evaluation for the airway. So we'll let you know once this course is out, and you can happily register for the same. I hope I answer your question.
Very good. Thank you. I will add one component to this. There's a follow-up question on that said, is this conference going to be available on demand? And I know there was a couple of chat messages about that too. So for the audience, just to let you know that we do record our webinars, and it takes us about a week, but then we put those up on our website in our educational resource area so that you can access all of those past webinars. Okay, our next question came in about age limits. Is there any age limit that for the patient for when you can use POCUS?
No age limit as far as pediatric airway is concerned. But age limit, yes, for the adult if you use this point of care in adult. See what happens, the calcification starts, as age goes. if the cartilage is calcified, the inner structures, the airway, inner airway lesions are difficult to identify because of this ultrasound rays cannot penetrate the calcified cartilage. So we have gone through till age 17, 18. In fact, in adult also, we have seen the vocal cord mobilities and lesions were pretty appreciable, but some minor lesions like leukoplakia or small areas which is involving in the small areas of airway were difficult to find because of some limitations of ultrasound. But in pediatric airway, no, till up to 18 or 17 you can easily go with that.
Okay, great. And another question is coming in about certification. Is there any certification required to do this?
No, as I told you, American Medical Association has already, given the approval and given the resolution point number 802 that any specialty who is using this ultrasound device for in their specialty as well, you are allowed to do that. But you should know how to do that. What is the normal, what is abnormal, and give the authentic results. So it would be good if you certified yourself. You will be a little safe medico-legally as well. So that's the thing. Better to go for the certification. That's all.
Very good. And for those of you that are maybe not familiar with all the products that the POCUS Certification Academy has, we do have certificates and certifications available in various content areas. So we just encourage you to check out our website and see if there's anything there that is of interest to you. Okay, so let's move on to our next question for Dr. Deepa. Can we also use ultrasound in diagnosing subglottic hemangioma or monitoring its response to treatment?
Yes, thanks for asking this question. We had one child, in fact. See, initial phases of hemangioma, it is pretty easy because you can see the bulge, you can see the narrowing of airway, you can see some isoechoic, presentation that definitely this is not the artifact, this is something else. But this is not easily diagnosable. You will see there is some lesion, but you cannot confirm that, yes, this is the hemangioma unless you do the direct laryngoscopy. Once you have confirmed child is already on propranolol, age, weight appropriate dose, then it is easy to see the shrinking of that lesion. Then you can keep the child on regular monitoring. In fact, I'll tell you, not even this, the laryngeal papillomatous kits, we have our extensive series with juvenile laryngeal papilloma, where kids comes with this lesion and it is difficult when to take for second laryngoscopic examination, and we just clinically judge, okay, hoarseness is increasing or voice changes increasing, what to do, when to take. Usually between gap of 2 to 3 weeks, we call them for the debulking of lesion. There the ultrasound has helped us a lot. We just screen the airway, we see how bad or good the bulk, disease burden is, then we take a call. So serial monitoring with the ultrasound is really, given us a great help in case of juvenile papillomatous lesion. That is why we are going to present next in my talk that rescue laryngoscopy, focus in rescue laryngoscopy.
Very good. Okay, and then a follow-up question to that, are you providing training online?
Yes, I think Point of Care Ultrasound Academy is a better person to answer on this question. Are you providing training online?
Sure. Yeah, and I wasn't sure if they were talking specifically to you, if you had any online courses that you were doing through your network, or of course I can answer for the POCUS Certification Academy. We do have what we like to refer to as micro learning opportunities. There's all kinds of information on our website. Of course, as Dr. Deepa noted in her talk, she's going to be talking about this particular topic at our POCUS World virtual conference coming up September 17th and 18th. So you can get more information on our website about that. But so there are different types of trainings that the POCUS Certification Academy has available. You can just check out our education resource section on our website. Okay, so let's move on to our next question. The question reads, thanks for the concise talk, Dr. Deepa. What about cases like huge lymphatic malformations extending into the thoracic region? Will POCUS be helpful and it obviates the need for MRI in surgical planning?
Okay, I would say no for this. Okay, first of all, we are going through the sternum, which is again difficult, more the calcification, difficult to see inside. And other way also, I would say no, because if you are saying the lesion is so extensive, child definitely need MRI for detailed surgical planning, because this is not some tiny surgery, or it's not the avoidance of surgery. You have to perform. So before that surgical resection or your surgical planning, you need to see what the extent of the disease. That extent you cannot get till we get further high frequency, fine probing in this field. But yes, I think follow up. If you are not going for the surgery, you want to follow up the child on the upper airway, then it is a good tool that you can see the size if you are using the sclerotherapy option for the child.
Okay, great. And thank you, audience, for all the questions. Keep coming, keep them coming. We've got a few more to go through, but we do have some time here for questions and answers. So if you have questions out there, go ahead and get them in the Q&A box now. Next question for you, Dr. Deepa. Is there any intraoperative use for POCUS?
Yes, intraoperative there is. Thanks for reminding me. I was almost in trouble a few days back. We had a child, 5 years old child, who tracheostomized twice, twice decannulated, again came with the Stridor. Child was having no case of subglottic stenosis, balloon dilatation was performed, decannulated, again probably re-stenosed, and child was in Stridor. Nobody attempted to secure the airway in PICU, assuming that there must be again re-stenosis of the trachea. Emergency tracheostomy was performed. We took this child, but I did this child again similar way, the way we do ultrasound evaluation. I found there was a subglottic stenosis. The diameter was 3 mm only, right? 3 mm. I spoke to my consultant. I spoke to my anesthetist that, see, I could see the subglottic stenosis, the diameter only 3 mm. So I don't think so. Your 3 size tube will also go, which comes with the outer diameter of 3.2. So either we keep 2.5 size tube available, or just go with the bag and mask, and we have to land up in the local anesthesia and finish it off. They tried 3, they couldn't pass. They did bag and mask. We immediately performed under local. While performing local, I was just lost for a few minutes. Everything was fibrosed. No muscular structure, no normal anatomy. As I told, twice tracheostomized, both time in emergency, everything was distorted. Then this point of care ultrasound, this ultrasound device helped me. I just shout out for that, get the ultrasound machine. I got the probe. After exposure, I kept the probe there and trachea was right there. After seeing that, we were a little confident. We just aspirated the air, trachea was there. We gave the incision and secured the airway. So yes, if you talk about ENT, there is an intraoperative role. If you talk about the anesthesia side, there is an intraoperative role for the intubation. To secure the airway, to look for the diameter, that's all. So yes, there is intraoperative role for point of care ultrasound.
Okay, very good. And it looks like we do have one more that have come in. One more question has come in. So how much time is required to get good learning, a good learning curve for daily practice? How much time does it take to learn this?
It's very subjective question. It depends on you, how much you are interested. It depends on you, how much time you want to devote. It depends on you, which certification course or trainer or mentor you select to learn about this. It's again depends on you and your practice, what all cases you are getting to, get more exposure. So I cannot answer this. What is the time? I think you just calculate what all time you need and you can devote for the same.
Okay, very good. Thank you. There's one more that just popped in. Sorry, I'm just reading it here. Can you comment on the use of POCUS to predict post-extubation stridor?
Yes, of course, there is a role. And in fact, there are documentations. There are recent publication who has done, I think, some 67 cases of intubated cases. And after that, they check how many were having, again, the tracheal diameter evaluation. and they found that they could significantly picked up the post-extubation edema on the trachea with the help of point-of-care ultrasound. You can mail it to me. If I get that article again, I will be happy to share that article with you. Yes, there is a role,
Very good.
and it has been established with the publications as well.
Okay, very good. Well, I'm looking to see there's no other questions that have come in. So I think that will end our question answer session. So I am going to bring up for the attendees one more poll question. So if you could take a moment, should be on your screen now, take a moment and answer that question. We certainly appreciate that. And while that's up, I am going to go ahead and turn the mic over to Hanjin for a short message from Mindray, our collaborator on this webinar. Go ahead, Hanjin.
Okay, thank you once again.
Okay, thank you, Tori. Thank you, Dr. Deepa, for this very practical and timely presentation about kids' airway. I learned a lot. Now, on behalf of Mindray, I want to briefly introduce what we do and what we can provide to make doctors better equipped with the equipment, so you can have a faster and easier access to point-of-care ultrasound. My name is Hongjin, by the way, and I'm associated also with ARDMS for quite a few certifications at the same time. And Mindray, as a leading manufacturer in point-of-care ultrasound, we provide 10+ mobile ultrasound machines dedicated for point-of-care ultrasound. Here, I'm just showing you a few. On the left is T7, which is totally tablet-based. In the middle, we have M6, which is for value range point-of-care ultrasound. In the middle, we have M8, which is a high-end ultrasound system dedicated for POC and also for basic cardiac. On the right side is our MX, which is newly released this year. It's got half buttons and half touchscreen, which is a good combination for both easy control and also for cleaning. And in summary, we want to provide our doctors with and physicians and also clinicians, anybody who's using ultrasound for POC. We provide fast and easy to access ultrasound, which is intuitive. And also our T series and MX series is very easy to clean, which is the right solution, especially during COVID-19, where disinfection is very important. And also the machines are very smart. We provide AI, artificial intelligence, for cardiac, lung, IVC scanning, because doctors in POC and clinicians are very busy. And it's also about time to save the patients. And also we provide navigation for needle injection. It's called an e-special navi. So to give the doctors much more precision when they insert the needles into the tissue. So that is my part of a brief introduction of Mindray solution. And again, thank you so much for your attention, and we hope to be your partner in the future. Thanks.
Great. Thank you, Hanjin, and thank you to Mindray for being a collaborator on this webinar event. We appreciate you being here. And now I am going to go ahead and turn it over to Sam with a few words from the POCUS Certification Academy.
There we go. Just wanted to make sure my lighting was right. Good morning and good evening, everyone. Thank you all for joining us. My name is Sam. I am the Global Manager of Outreach for the POCUS Certification Academy, and I helped coordinate this webinar with our POCUS Ambassador, Dr. Deepa, and with Mindray. We've been planning it for several months, so we're so glad that everyone could join us here this morning. As we reviewed in our poll, we do know that any clinician can practice point of care ultrasound, and we're seeing more and more applications across all practice settings, including nursing, including emergency med, critical care, ICU. We're seeing it in chiropractics. Even veterinarians are starting to utilize POCUS. So this is really, really innovative. And we are so glad that Dr. Deepa showed us this great application in ENT, also with pediatrics. And I think that's so important to have a non-invasive technology that we can utilize, especially with young people. I especially want to thank Dr. Deepa, our POCUS ambassador to India. She has been a wealth of knowledge, and she is also helping us develop a new certification specific to her topic today. And so you'll see that coming soon. We also want to thank Hong Jin and our partners at Mindray. This has been a really fantastic event, and we hope to do many more international webinars like this. If you enjoyed today's talk, you can see more from Dr. Deepa and from over 50 other international presenters at the POCUS World Conference. Thank you, Tori, for putting up the slide here. You'll see it is September 17th to 18th. There are many, many different speakers and presentations. There will be an exhibit hall where you can see different vendors and different devices. You'll also be able to network with other POCUS enthusiasts. So we really, truly invite everyone to come. And if there are scholarships available, if cost is an issue. So do ask us about that. And if you're looking for training, as Tori mentioned, we do webinars like this every month at the POCUS Academy. We also offer podcasts, educational blogs, and of course, the POCUS World Conference is an educational event. So we would love to invite you all to attend. And then, of course, we also have our POCUS Education Provider Program, and you can look at that online. There's up to about 15 different training companies across the world who offer online and in-person training. And we encourage everyone to seek training and then to get certified. Again, I want to thank Mindray. I want to thank Dr. Deepa Shivnani, and to thank everyone here who is still listening along. We hope that you'll join us at our next webinar. And with that, Tori, I'll pass it back to you.
Thank you. Thank you, Sam. Appreciate those words. And from me as well, thank you to Dr. Deepa, to all of you attendees, and to Mindray for the collaboration on this webinar. That does wrap up our session today. So a recording of this webinar will be made available on the POCUS.org website in approximately a week. Thank you for attending our webinar today, and we look forward to seeing you on a future webinar. Thank you.
Thank you, everyone. Thanks, Tori. Thanks, Sam, for joining us. Thank you, Hong Jin. Tthank you all. Bye.
Great job, Dr. Deepa. Thank you all.
Thanks, everybody.